If you search for whether forgetting words is a sign of dementia, here is the honest answer in the first 60 seconds. Sometimes, yes. But for most adults over 50, most of the time, word-finding difficulty is not dementia. It is normal aging, fatigue, anxiety, or disrupted sleep. The experience of a word that was just there and then is not is one of the most universal cognitive experiences of midlife and beyond. But there is a specific pattern of word-finding difficulty that is different from that normal experience. And it is associated with early Alzheimer's disease. The two patterns are distinguishable. Knowing the difference between them is exactly what this video will give you. By the end, you will know what to watch for, what to leave alone, and when to take this concern to a doctor. Most health content gets this question wrong in one of two directions. Some content reassures too quickly. Forgetting words is completely normal as you age. Don't worry about it. This is too dismissive. There is a real pattern of word-finding difficulty that is a meaningful marker of early Alzheimer's disease, and dismissing the concern entirely is not honest. Other content alarms too easily, listing forgetting words alongside severe late-stage dementia and creating the impression that a lost word means a diagnosis is coming. Also, not honest. The accurate answer is more specific than either of those because there are different types of word-finding difficulty. They have different mechanisms, different clinical significance, and different implications. Is forgetting words a sign of dementia? Cannot be answered yes or no. The answer depends on which type of forgetting you are describing. That specificity is what this video provides. Not a reassurance or an alarm. A framework that lets you look at what you are actually experiencing and make an informed judgment about it. To understand what word-finding difficulty actually means, you need to understand how word retrieval works, because the mechanism explains exactly what is happening when it fails. Words are not stored in the brain like dictionary entries. They are stored as networks of associations. A single word, apple, is simultaneously linked to its sound pattern, its spelling, its visual image, its smell, its taste, its category membership. Retrieving a word requires activating multiple brain regions simultaneously. Wernicke's area, in the left temporal lobe, stores the semantic content of language, the meanings of words, and the networks connecting related concepts. When you think of the concept scissors, this region activates the semantic network surrounding it, cutting, paper, handles, blades. Broca's area, in the left frontal lobe, handles language production, the motor planning of speech, and the grammatical organization of sentences. The angular gyrus bridges visual, auditory, and linguistic information, connecting what things look like with the words that name them. The hippocampus plays a role in updating the mental lexicon, strengthening infrequently used associations, and binding the components of word knowledge together. When retrieval fails, it is almost always because one link in this distributed network has been temporarily or persistently disrupted. The concept is intact. The meaning network is intact. But the pathway to the word's sound pattern, its phonological form, has been blocked. This is why the tip of the tongue experience feels the way it does. The meaning is entirely accessible. You can describe what you mean. You might know the first letter or the rhythm of the word. The concept is there, only the sound pattern is temporarily unavailable. Understanding this, that word retrieval is a multi-region process rather than a single lookup, is essential for understanding why different types of failure mean entirely different things. Subscribe now and help Dr. Manu Jones reach the people who need this. The first type is the tip of the tongue state, the TOT experience in the research literature. The feeling of being certain you know a word, feeling it just out of reach, and being unable to produce it. This is universal. It happens to every human being with language at every age. Research by Deborah Burke and colleagues confirmed that the tip of the tongue state is a normal feature of language retrieval, not a sign of cognitive decline. It does become more frequent with age. This reflects a well-documented age-related slowing of processing speed. The brain takes slightly longer to activate the phonological form of a word, creating more opportunities for temporary blocking. This is normal and expected, not pathological. The characteristics that define a normal TOT experience. The word feels close. You have the strong sense that you know it. It is accessible, not absent. You might know the first letter or the rhythm of the word. This partial activation of the phonological pattern is a hallmark of TOT. The word returns on its own. usually later when you stop straining for it, after competing words that were blocking the target have quieted down. The word comes back when given a hint. If someone else says the word or a rhyming word, it becomes immediately accessible. This responsiveness to external cueing is specific to the normal TOT state. The failure happens most with less common or less recently used words, names of acquaintances, titles of books, specialized vocabulary from a field you no longer work in, not with words you use every day. If this is what you experience, the word feels near, returns on its own or with a hint, happens mostly with names and infrequent vocabulary. This is a normal tip-of-the-tongue experience. It does not indicate dementia. It indicates a brain that takes slightly longer to access a specific sound pattern, which is exactly what the research predicts across the normal lifespan. The next type is different, and this is the one research has specifically linked to early Alzheimer's pathology. The second type is called circumlocution, talking around the word you cannot find. Instead of the word itself, you describe the object or concept, its use, its appearance, its category, because the label has become inaccessible. Here's what this sounds like. I need the thing for cutting, with 2 holes for your fingers. That is circumlocution for scissors. Can you pass me the thing for opening cans? The metal thing in the kitchen. That is circumlocution for can opener. This is not the same experience as tip of the tongue. In tip of the tongue, the concept is fully present and the phonological form is temporarily blocked. You know the word exists, it feels close. You might know it starts with S. In circumlocution, the relationship between the concept and its label has been disrupted. The person still knows what the object is, they can describe its function and appearance perfectly, but the word that names it is not just blocked, it is disconnected from the concept. This distinction reflects what is happening in the brain. Tip of the tongue reflects a temporary problem with phonological retrieval, the sound pattern. Circumlocution reflects a disruption in the semantic network, the meaning connections linking the concept to its label. And it is the semantic network, anchored in Wernicke's area and the surrounding temporal cortex, that Alzheimer's pathology reaches as it spreads from the hippocampus. Linguistic research using the Dementia Bank corpus, recordings of speech from people at various stages of Alzheimer's, has found circumlocution patterns in early-stage Alzheimer's speech, often years before formal diagnosis. The features that distinguish circumlocution from normal word finding. It happens with common everyday words, not specialized vocabulary or names. A person does not circumlocute around a technical term from their profession. They circumlocute around scissors, calendar, refrigerator, words used daily for decades. The word does not return with a hint. If you say scissors, they recognize it immediately, but they could not access it independently. And the next time they need it, the same failure may occur. The frequency has increased over months. It was occasional. It has become regular. It happens with words from multiple areas of daily life, not just one category. This specific pattern, common words, no independent retrieval, increasing frequency, multiple categories, is the one worth paying close attention to and worth discussing with a doctor. The third type is anomia, the medical term for word-finding difficulty that goes beyond tip of the tongue to something more complete. In anomia, the word is not temporarily inaccessible, it is simply absent. There is no sense of it being close, no partial activation, no first letter, no rhythm, no feeling of nearness. The person searches and finds nothing, not, it's on the tip of my tongue, just an absence. Anomia exists on a spectrum. Difficulty with infrequent or specialized words is common in normal aging and in conditions like fatigue and depression. Consistent difficulty naming common objects encountered daily is a significant clinical sign. Anomia is one of the earliest and most consistent findings in primary progressive aphasia, a language-specific neurological condition distinct from Alzheimer's disease. It is also a feature of Alzheimer's disease, often appearing in parallel with circumlocution as the semantic network is progressively disrupted. The features that suggest anomia rather than normal tip of the tongue, the word does not feel close. There is no sense of partial access, no first letter, no competing words suggesting the right one is nearby. The search finds nothing. The word does not return. Not an hour later, not the next day. When a familiar word consistently fails to return, that is meaningfully different from a word that surfaces later when the pressure is off. It is happening with words used regularly, not names of people seen rarely, not specialized terms from a former career. Ordinary objects of daily life. In practice, anomia and circumlocution often appear together. The person cannot access the word, anomia, then describes the object instead, circumlocution. Both are present simultaneously. The fourth type is paraphasia, substituting one word for another. The feature that makes this clinically significant is specific. The person does not always notice that they said the wrong word. There are two varieties. Semantic paraphasia substitutes a related word, chair for table, daughter for granddaughter, pen for pencil. Phonemic paraphasia substitutes a similar sounding word, spoon for moon, fan for can. The substituted word shares the sound pattern of the intended word rather than its meaning. Everyone occasionally substitutes words. These slips of the tongue are universal and not clinically significant when they occur rarely, and the person immediately notices and corrects them. What makes paraphasia worth attention is consistent occurrence combined with reduced awareness of the error. When someone consistently says the wrong word and does not notice, or only notices when pointed out, this reflects disruption not just in word selection, but in the brain's self-monitoring system for language. The breakdown is in the checking mechanism that normally catches the error before or immediately after it is produced. Consistent paraphasia, particularly without self-correction, warrants neurological evaluation. Not one isolated instance, a pattern. The most common causes of word-finding difficulty in adults over 50 are not Alzheimer's disease. They are fatigue, sleep disruption, anxiety, depression, thyroid dysfunction, vitamin B12 deficiency, and medication effects. Most word-finding complaints that reach a neurologist's desk are ultimately explained by one or more of these. Sleep deprivation is probably the single largest contributor to word-finding difficulty that gets misattributed to aging or dementia. Language retrieval is one of the cognitive functions most sensitive to sleep quality. A single night of significantly disrupted sleep produces measurable declines in verbal fluency the following day. If your word finding is worse after poor sleep and better after good rest, sleep is the most important thing to address first. Anxiety about word finding has a specific and ironic property. The anxiety makes it worse. When the brain actively monitors itself for retrieval failures, watching each sentence for the missed word, cognitive resources are diverted from the retrieval process itself. The self-conscious search for errors competes with the automatic processes of language production. Many adults in their 50s and 60s begin monitoring their own word retrieval, notice more failures, and conclude something is worsening, when what has changed is the monitoring, not the retrieval. Depression produces cognitive slowing, including language retrieval effects that can closely resemble early dementia. When depression is treated, word finding often improves substantially. Thyroid dysfunction, particularly hypothyroidism, is a well-established cause of cognitive slowing, including reduced language fluency. A blood test identifies it. Treatment resolves it. Vitamin B12 deficiency affects myelin, the insulation around nerve fibers, and produces neurological and cognitive changes, including word-finding difficulty. Common in older adults and in people on long-term metformin or proton pump inhibitors. Medications are frequently overlooked. Anticholinergic drugs, certain antihistamines, bladder medications, some antidepressants directly impair the neurotransmitter system that language retrieval depends on. Benzodiazepines and some blood pressure medications can also produce cognitive effects. The clinical reality. When an otherwise healthy adult over 50 presents with word-finding difficulty and no other cognitive symptoms, the most common finding is one of these reversible contributors, not early dementia. This is the actual epidemiology. When you bring a word-finding concern to a neurologist, here is what the evaluation typically involves. The clinical history comes first. When did this start? How often is it happening? Which types of words are affected? Names, everyday objects, professional vocabulary. Does the word come back later? Have other people noticed, or only you? Are there other cognitive changes? Difficulty navigating familiar routes, missing appointments, repeating questions within short periods? This history already tells the clinician a great deal. A person who says, "It happens occasionally, it's mostly names, the word usually comes back, my family hasn't noticed anything," is describing a very different clinical picture from a person who says, "It is getting worse, it is happening with everyday words, my partner has started mentioning it." Neuropsychological testing follows if indicated. The standard tool is the Boston naming test, pictures of objects ranging from common to uncommon, with the person asked to name each one. The test is calibrated for age and education norms, so a result can be compared against what is expected for that specific individual. Verbal fluency tests are also standard, generating as many words as possible from a category or a letter in 1 minute. Category fluency and letter fluency tap into different aspects of the semantic and lexical networks, and their relative impairment can point toward different underlying conditions. Blood tests screen for reversible causes: thyroid, B12, metabolic panel, complete blood count. Brain imaging may be ordered if there are additional neurological signs, if the history suggests a vascular or structural cause, or if initial evaluation raises clinical concern. The important distinction in this evaluation: subjective cognitive concern, you notice something that worries you, versus objective cognitive deficit. Testing reveals a measurable departure from expected performance. Many people who present with significant subjective concern about word finding show normal performance on objective testing. Normal testing is reassuring, but it does not exclude early pathological change that has not yet reached the detection threshold of standard tests. Let me be specific about when word-finding difficulty warrants medical evaluation. See a doctor if the difficulty has clearly worsened over 6 to 12 months, not one bad week, a sustained progressive change that you and people around you can observe. People close to you have noticed before you mentioned it. When a spouse brings it up without being prompted, or a colleague asks if you are all right, that external observation is clinically significant. The change is visible from outside. It is happening with common, everyday words, not names of distant acquaintances or specialized vocabulary. When refrigerator, calendar, or newspaper are consistently hard to access, discuss it with a doctor. You are avoiding situations because of it, ducking out of complex conversations, deferring to others where you previously led, structuring sentences around words you know you can access rather than the ones you actually want. This compensatory avoidance is a meaningful signal. The word finding is accompanied by other changes: navigating difficulty, missed appointments, repeated questions or stories. You do not necessarily need to see a doctor if the difficulty is specifically with names of celebrities, people you know moderately well, titles of books. Name retrieval is the most age-sensitive aspect of language, and the most affected by normal aging. The word comes back on its own or with a hint from someone else. The difficulty fluctuates with sleep quality, stress, or anxiety, and improves when those factors are addressed. No one around you has noticed it, and you have not been avoiding situations. For most people watching this, here are the things with the best evidence. Sleep is the first and most important. Before concluding that your word finding has worsened permanently, assess your sleep quality honestly. If you are sleeping 6 hours or fewer, or waking frequently and unrefreshed, address this first. A meaningful proportion of word-finding complaints that are resolved simply by improving sleep. Reduce the self-monitoring. The more you watch yourself for retrieval failures, the more you will notice them, and the more the monitoring competes with the automatic processes of speech production. When you are in conversation and searching for a word, let the conversation continue rather than stopping to force it. The word surfaces more reliably when you stop actively hunting. Zone 2 aerobic exercise. Exercise-driven BDNF production supports the hippocampal and cortical systems underlying language. Verbal fluency benefits from aerobic exercise specifically have been demonstrated in research populations. 150 minutes per week of moderate intensity aerobic exercise is the threshold at which measurable cognitive benefits appear. Address reversible causes directly. A thyroid blood test and a B12 level are inexpensive. Between them, they cover 2 of the more common reversible causes of word-finding difficulty in adults over 50. A medication review, specifically for anticholinergic drugs and benzodiazepines, is worth doing with your doctor if you take any. Demanding social conversation. Not passive social time, complex discussion that requires you to construct arguments, track someone else's reasoning, and respond in real time. This exercises the language network specifically. Let me give you the honest assessment this video promised. If you are watching because you had a frightening episode of losing a word mid-sentence, take the concern seriously enough to monitor it, but not seriously enough to conclude a diagnosis from a single experience. One episode, even a striking one, is not a diagnosis of anything. A pattern, sustained over months, that fits the specific features described in this video common words, no hint responsiveness, increasing frequency, combined with other cognitive changes or noticed independently by people close to you. That is worth a medical conversation. The most likely explanation for most people watching this is not Alzheimer's disease. It is the normal deceleration of language retrieval, combined with fatigue, sleep disruption, anxiety, or medication effect. These are real, common, and respond to specific interventions. If you are still uncertain after watching, that uncertainty is itself a reason to have the conversation with a doctor. Bring a specific description of what you experience, which types of words, whether the word returns with a hint, whether others have noticed, how the frequency has changed over the past year. A clinician who hears that specificity can evaluate your concern properly. The goal of this video was to replace vague worry with specific knowledge. If it has done that, you are in a better position than when you started. Here is what this video covered. 4 distinct types of word-finding difficulty. The tip of the tongue state is universal and not clinically significant on its own. It increases with age, and the word returns with time or a hint. Circumlocution, talking around a common word because the label is disconnected from the concept, is the pattern most linked to early Alzheimer's pathology. Anomia is the absence of a word without any sense of nearness. Paraphasia, substituting the wrong word without consistently noticing, reflects disruption of the language monitoring system. Most word-finding difficulty in otherwise healthy adults is not Alzheimer's. Sleep deprivation, anxiety, depression, thyroid dysfunction, B12 deficiency, and medications are far more common causes, and each is addressable. The pattern worth monitoring. Common everyday words, no return with hints, increasing frequency over months, combined with other cognitive changes or noticed by people around you. One question in the comments. Has your word finding changed with sleep quality, stress, or a medication change? I read every comment. If this gave someone you know a framework for a concern they have been carrying alone, share it. If you have stayed with me until this point, I have something special for you, a small bonus. For the next few minutes, you do not need to learn anything, you do not need to remember anything, and you do not need to solve anything. We are simply going to spend a few quiet minutes together. This gentle meditation is designed to help you slow down, feel calmer, and bring your attention back to the present moment. If you are living with memory difficulties, or if you sometimes feel confused or overwhelmed, that is okay. There is nothing you need to get right. Just listen to my voice. First, find a comfortable position. You can sit in a chair, rest on your bed, or simply stay wherever you already feel safe and comfortable. Let your hands rest gently. You can close your eyes if that feels comfortable, or you can keep them softly open. Now notice that you are here, right now. You are listening to my voice. You are safe in this moment. There is nowhere else you need to be. Now take a slow breath in through your nose. Not too deep, just comfortable. Breathe in. And slowly breathe out. Again, slowly breathe in. And gently breathe out. One more time. Breathe in comfortably. And breathe out slowly. Now allow your breathing to return to its natural rhythm. You do not have to control it, simply notice it. Breathing in. And breathing out. Now gently notice your forehead. You do not need to change anything. Just allow your forehead to soften. Let your jaw become loose and comfortable. Let your shoulders drop slightly. Let your hands rest. Let your legs rest. For these few minutes, your only job is to be here. If thoughts appear, that is completely normal. Maybe you remember something. Maybe you forget what I just said. That is okay. You do not need to chase the thought, and you do not need to push it away. Simply return to one easy thing, your breath. Breathing in, breathing out. Now I want you to notice one simple feeling, the feeling of your body being supported. Maybe the chair is supporting you, maybe the bed is supporting you. Notice that support. You do not have to hold everything by yourself in this moment, just rest. Now quietly listen. Notice any sound around you. A distant sound, a quiet sound, or perhaps only the sound of my voice. There is no correct sound to notice. Just listen. And now gently return your attention to your breathing. In and out. As you breathe out, imagine that your body is becoming a little softer, a little quieter, a little more settled. You do not need to remember yesterday right now. You do not need to worry about tomorrow right now. For this moment, there is only this breath. This breath in, and this breath out. Now silently repeat these simple words in your mind. I am here. I am breathing. This moment is enough. Again, I am here. I am breathing. This moment is enough. Now we are slowly coming toward the end of our meditation. There is no need to rush. Notice your hands again. Notice your feet. Notice the room around you. Take one comfortable breath in and slowly let it go. If your eyes are closed, you can gently open them whenever you are ready. Look around you slowly. Notice where you are. Specific knowledge replaces vague worry. Subscribe for new videos every Tuesday and Friday.